Hi everyone, it's Mandy from West Coast Therapy Specialists Occupational Therapy, and I wanted to talk to you today a little bit about some of our residents that might have issues with self-feeding. First, if you notice any of your residents that might have a decline in their independence in self-feeding in terms of managing the utensil, loading the utensil, chewing, swallowing, anything like that, you definitely always want to refer them to, of course, your DON at your facility as well as the therapy department so that we can assess them and see if there's something we can do to make them more independent in feeding and help you, of course, with your job. So I'm going to talk a little bit about a few things that might make them more independent in feeding and some of the problems that you might see the residents start to have. So the first thing, you might notice that depending on what the resident is diagnosed with, they could have a lot of shaking when they're trying to manage their utensils. So sometimes for occupational therapy, we'll train the resident in using a weighted utensil. What the weighted utensil will do is keep the hand from shaking. They are loading the utensil and doing the coordination from the plate to the mouth. Again, that would be something that we would have to evaluate them for and treat them for so that they can practice using the utensil and so that we can make sure it's a good fit for them. Now, of course, if they're shaking too much and they're also too weak to handle the weighted utensil, we would want to take another approach, which is, again, another reason why you always want to come to us and have us take a look at what's going on with them so we can evaluate them and treat them best. Second, I want to go over built-up utensils. These are more for people that have issues with grasping the utensil. Maybe they have fine motor coordination issues. They're not able to hold the utensil the way you're traditionally taught to hold it, and they want to hold it like this so that they can still manage the food, they can still coordinate, and they can still bring it to their mouth and using a adapted motor planing technique, which again is something that we'd work on with them in therapy. These utensils can also be bent. Like you see the fork has been bent. They can be bent and angled so that it's easier for them to scoop it and just bring it to their mouth like that. So it depends on how much range of motion they have in their shoulder, their elbow, and their wrist. Will depend on how much we need to bend it and will depend on what kind of utensil we're going to use with them. I want to talk a little bit about the different types of plates we have. So this right here is a scoop plate. You can see that one side is raised up a little bit more than the other side. We'll usually place that raised side facing towards the resident so that when they are scooping, they can just go right up against it, load the utensil, and then bring it to their mouth. They don't have to worry about manipulating it, making sure it doesn't fall off the plate or in their lap, and that way they're able to consume more of their meal quicker with less spillage. Now, I don't have an example here, but we do have divided plates. They're usually divided into 3 separate sections, and that can also help a resident who has issues with scooping the food and might have a problem with the food getting mixed together. Or a resident that has vision issues. So if a resident has vision deficits and they're not able to see the food on the plate, if you have a divided plate, you can tell them your meat is at 3 o'clock, your potatoes are at 6 o'clock, and your dessert is at 11 o'clock. And they're able to remember, based on the divided plate, where they can get the different items from. That way they're not eating their apple cobbler before they're eating their meat. So again, this is something that we will evaluate and assess, make sure that it's appropriate for them, and see where we go from there. Also, sometimes you might notice that a resident is having problems manipulating loose items like rice or peas, things like that. In that case, then we might work on going towards something like finger food, something that they don't need silverware for. If the resident is in agreement with it, then that is something we could evaluate and work on with them as well. So there are lots of different solutions, and something that we always want to trial and error with, make sure that the resident's happy with the solution and make sure that it works for them, make sure that they have carryover and that the staff member doesn't need to be there to do it with them every meal, because if you have to be with them every meal to do it, then that defeats the purpose of us training them. So the ultimate goal is for them to be more independent, consume as much of their meal as possible, and with decreased spillage. Question number 1. You notice that your resident, Mrs. Smith, has been feeding herself independently for the past year, but for the past few weeks you notice she's spilling an increasing amount of food, even though she claims she doesn't have a problem feeding herself. What is the appropriate plan of action to take? Question number 2. The therapy department has treated Mrs. Smith for shaking and utensil manipulation, and given her built-up utensils to feed herself with. You notice that they worked at first, and then now that it's been a couple weeks, she's having trouble again and she's spilling her food. What is the appropriate plan of action to take? Question number 3. You notice that your resident, Mrs. Smith, is able to feed herself, but she gets fatigued very easily using utensils, and she often stops eating before she is full. What is the appropriate plan of action to take?